Drgaboneqhsc QHSC.
Hello everyone, my name is Dr. Drgaboneqhsc and I am so excited to introduce to you QHSC Health Conversation Series. And so this health series will be including different topics, and we get different expertise globally to come and discuss their experiential clinical practice and what we can learn from there. And we always have an angle to address the client or patient's perspective, because our goal is to increase client participation or client compliance, to engage them or to encourage them to be part of their care. So all our knowledge and expertise will be served well if our client or patients understand what we are telling them, what diagnosis they receive, and what they can learn from it in order to regain their health status. So today we're going to start doing the first QHSC Health Conversation Series, and it's going to be geared to diabetes and customer service. As I said, our goal is to provide education and training for all the healthcare workers, and also engage in a community outreach project. Apart from the community outreach project is to include the client or patients to be active in their health practices. So I'm excited to have so many experts who are willing to spend time with us. Without further ado, I'm going to get you to introduce and meet them for today's QHSC Health Conversation Series. Welcome and enjoy. No, I appreciate that. No, thank you very much. I mean, I know you're busy, but I appreciate your time, definitely, because it's a much needed knowledge, definitely. I'm going to be like choosing one topic, and then we have to explain from healthcare standpoints and client standpoints, meaning that we have to be able to share our knowledge, and then from physician standpoint, then you share your expertise, and then from nursing standpoint, and then from pharmacy standpoint. All this, we are trying to educate the clients. So of course, the clients we're referring for people who are not in the hospital yet, but still seek clinical services. And then when they're coming to the hospital, if we're talking about the scenario has a patient in there, so definitely we're going to refer to patient so everybody knows what we're talking about. So we are going to have definitely a physician on board to be able to explain some of the, physiology and the pathology of the disease we're discussing, just briefly, and then give us their expectation, like what they expect the patient to have or client to have according to that diagnosis. And then what is the expectation after the client comes and see them, to be able to explain what is happening with their diagnosis. And then our goal at the end of this, we want the client or the patient to be compliant. One way to get them compliant is to participate on their own care. So it's our responsibility as nurses and physicians and pharmacists to try and educate the patient so they can be part of their own self-care. So today's topic is diabetes and customer service, because anytime you provide care for the patients, you have to include customer service, meaning that how is the patient going to be involved? How do we treat the patient during those services? And what do we expect them to go home with, like means the discharge instruction to continue with their care? So that, I'm going to give Dr. Mlawa some time to introduce himself and then give us a little background so we know. I mean, I know he's an expert in this area, but I want to make sure everybody else knows that he is the expert on this area, and we are fortunate to have him today to be able to join our group of discussion. As I said, we are joining these groups health, so QHSC Health Conversation. And then so today is diabetes, and I'm welcoming Dr. Mlawa. Welcome.
Thank you for allowing me to take part in this discussion today. My name is Dr. Gideon Mlawa, and I'm a consultant physician in diabetes and endocrine. Also, I do general medicine, and I'm based at Queen's Hospital in London. I'm the current training program director for internal medicine trainees, and recently I've taken the role of Royal College of Physicians as a college tutor. But I also do general diabetes clinic, and on those clinics, I'm able to see patients with diabetes in pregnancy or gestational diabetes. I'm a member of Royal College of Physicians as a fellow, and my interest is diabetes in pregnancy, diabetes and technology, but also medical education. And in today's conversation or discussion, I've been able to provide 2 scenarios of a patient I've seen before. And I'm looking forward to sharing these scenarios with all of you. Thank you.
Thank you very much, Dr. Mlawa. And to add to it, I really appreciate for you sharing these scenarios, because these are the scenario we call the experiential scenario, meaning like you have an actual patient experience this part, and then so when we were discussing, it gives us experiential learning, meaning that we are learning from actual patients who have been receiving care and progress through their disease, and then we can see what works and what doesn't work versus just creating a scenario. So I do appreciate for your time and providing this scenario, which we're going to go through. So the way we're going to be explaining that, I'm just going to read the top of the scenario and then give you what Dr. Mlawa provided. And then I'm going to allow Dr. Mlawa to go over the scenario, tell us what he provided to this client. And then I'm going to invite Ms. Kisa to explain from the nursing standpoint, having that patient as a nurse, what is the expectations of, and then we're going to get Mr. George from Tanzania explaining from the pharmaceutical part what the usual medication that they use for that patient. So we're going to start with the scenario for a 45-year-old lady with type 2 diabetes. This is a 45-year-old lady with type 2 diabetes. She has a high BMI, it is 127 and BMI of 41, and she's awaiting for bariatric surgery. So the medication she was provided was Trulicity. I mean, you can see a list of insulin and then some aspirin and metformin, they're listed there. So this is the patient that spoke with Dr. Mlawa by phone, and then the patient stated that her glucose level was between 6.8, and then there was no hypoglycemic event, and glucose levels were improving since she started basal bolus regime. She was waiting to have a mini bypass surgery or bariatric surgery in July 2020 last year. So I'm gonna let Dr. Mlawa continue. Go ahead, Dr. Mlawa.
So this is a patient I've been looking after for the past 2 years actually, and diagnosed as type 2 diabetes at the age of 23. So that's relatively, that's about 17, 18 years ago. But initially, when she's 45 now, but diagnosed as type 2 diabetes at the age of 23. She's a British Asian. So that tells us that younger patients who are type 2, but also apart from that, there was a family history of type 2 diabetes, and herself, when I saw her 2 years ago, she weighed about 150 kilograms, and that was, the BMI was almost over 45. And if you look at her medication when she was initially diagnosed, when I spoke to her, of course, initially she was tried on diet, okay, for up to 3 months. Then that and lifestyle modification, i.e. exercise, looking at that, weight loss, did not work for her. And it was put initially on metformin, okay? And then with that, she was progressing well. Then referred to my clinic because she was not improving. I think what brought her to our clinic was to make sure that even additional for her condition. So she's a relatively young lady. I saw her when she was 43. So she's 43. She's type 2 diabetes, overweight. So if you look at different medication we use for type 2 diabetes, of course, metformin is always number one, as long as there's no contraindication. If someone has got severe kidney disease, he cannot use, or she cannot use metformin. If they've got side effects to these medications, so one of the side effects of metformin, which is common, is gastrointestinal side effects such as diarrhea and vomiting or abdominal pain. So for this patient, she was tolerating well. But if you look at what would be the number 2 as add on to her treatment, would be a group of medication called sulfonylureas, such as glucoside. But the side effect of this medication is weight gain. So she's obese already. And that's why if you look at her medication, she's not on either glibenclamide or glucoside because she's overweight. Then when she came to me, what I gave was to give Trulicity is a medication is under a group called GLP-1 agonist. So the mechanism of action of Trulicity, of this medication, it inhibits appetite and therefore helps patients to lose weight. So metformin plus Trulicity is a good medication for this patient who is type 2, but also overweight. So one is going to ask me that the patient is already on insulin. The reason she was put on insulin when she came to me second time was that because she's very overweight, she went privately to pay for weight loss surgery, which we call bariatric surgery. So she was waiting gastric bypass, but one of the conditions for someone to go on the weight reduction surgery, you have to have a very good diabetes control because it's a big surgery. And if you just go and operate upon a patient with very high sugar levels, there's a risk of getting infections. So that's why she was put on insulin plus the metformin plus Trulicity to get a better diabetes control before going for her surgery. So the last time when I reviewed her HbA1c was about 53, that's A1C. 53 is about 7% when you use them. I think in America use 7%. So overall, this is a patient who's 45, diagnosed as type 2 diabetes at the age of 23. So when I saw her, she was referred to the GP to me because her control was not very good at the time, but she's also overweight. And if you look at the pathophysiology of type 2 diabetes, one of the contributing factors for type 2 diabetes is being overweight. So addressing the weight issue is one of the treatment where this patient with type 2 diabetes will be helped. So in summary, I've talked about a case of 45 years old lady. She's British but Asian, diagnosed as type 2 diabetes at the age of 23. Initially tried diet alone as part of treatment, plus other modifiable risk factors such as weight loss and exercise. It did not help, and the patient was put on metformin initially, which did not work, and as she continued to gain weight, she was keen to lose weight, and therefore she went privately to try and get weight loss reduction surgery, which is called bariatric surgery, and the choice of surgery for her was gastric bypass, and therefore we needed to optimize her diabetes before going for surgery, and that's the rationale for this patient being on both tablets and on insulin.
Okay, that is great to know, because that was also one of my questions. Like, okay, she's in the pills, the tablets, and then the insulin, so I wasn't sure what exactly why, but I appreciate you explaining, knowing that the patient is already obese at the young age of 45, and then and I appreciate you adding explanation of using Trulicity, because that usually, as a nurse, it helps me understand, okay, why the doctor ordered the insulin, why doctor ordered metformin, why am I combining? So knowing the reason behind it, that's the reason we have a meeting today, because just getting the orders from the doctors and go and administer to the patient, I need to understand why am I giving that? And I know some of the patients will ask, why am I getting both of them? So for you explaining that part, I do appreciate that, because as a nurse, I understand. Now my role as a nurse, I need to go and educate the patient. What exactly am I telling this patient to take, and why am I telling them to take it, and how am I going to assess the efficacy of this medication? Because if the medication helps at least minimize the chance of gaining weight, then at least I can say yes, because you've already have the obese range. So then I need to do something to be able to help you while we are managing the glucose. And then now I need to make sure to carry you over to the other side so you can maintain and control your glucose. Miss Kisa, using the scenario Dr. Mlawa went through, and as a nurse, either receiving this patient or preparing this patient to understand their diagnosis and what they need to do to improve their health, because that's the role of the nurse, educating the patients to return to her normal health range. So as a nurse, understanding this scenario, what are the things that you will do to prepare this patient, to educate this patient? And if the patient is anticipating having surgery, as a nurse, what are the tips that you can share with the patient to help them get to what they need to do? And if you have an example of a similar patient who has a similar diagnosis, please share.
Okay, good. Hello, everybody. This is Kisa from New York. I'm a nurse in ICU, CCU, and informatics nurse from United States of America. So thank you, Dr. Mlawa, for presenting this patient. I think the patient is, you explained very well, and I'm gonna play my part as a nurse. So first of all, I think I'll introduce my patient. I introduce myself to the patient, and then what the goal. Nurses cannot only work by themselves. It take a team to take care of this patient. So it's going to be a part of the doctors, has to be a part of the patient care, the nurses, social worker, pharmacy, and any other support this patient need. First of all, I'm going to have to know what the goal she have. And the goal, you see that apart from medication, also weight is an issue. So we have to make sure the dietitian has to be a part of a diet, what the diet she likes. We don't want to take it completely what she likes, but we're going to modify the diet she's eating. So she's not going to be too, so she's going to cooperate, because if we take diet completely from what she usually eat, she's not going to be a part of it. So we have to be very mindful that the diet is important. And we have to know what family support she have. Did she have family support? If she have family support, it's a time to involve them, because maybe they're the one who buying the food. So we have to put them in the team to help her. Even so, during if the patient is admitted, we're gonna do from day one when the patient is admitted. If the patient is just come in the clinic, also we can ask the support. So it's gonna be the part of the team. And also sometimes we may need to add psych. Why we do need psych? We may need psych because patient maybe she has underlying psych issues. And then if we do not address it, the food, that's the only comfort she have. And she's gonna continue to eat, even though we're doing medication, we're doing every other support. But if we don't address the psych issue, we're not gonna get to where we're supposed to do. And we have to know the patient know about the medication, because sometimes you come across the patient and you ask them, what medication are you taking? They say, oh, I don't know, ask my mom or ask somebody. Remember, this patient has been seen since she was 23. Now she's 45. So it's almost like 17 or 18 years being seen, been have type 2 diabetes. So all this issue, when we put it together, and then we will talk about the surgery, because surgery alone cannot do it. And there's a risk for the patient like this, when she go to the surgery with that kind of weight, and after the surgery, go back to the same habit of either eating or not exercising, is gonna be an issue. So that's the time we have to bring everything on the table. And then patient has to demonstrate that they understand, not just give information. And the patient, sometimes when they're in the hospital, they don't digest well. They'll say yes, yes. And then when they go, they say, oh, I thought. So you have to, okay, I teach you yesterday, A, B, C, D. What do you understand? Can you tell me a little bit? And they will talk about that. So it takes a team, it takes a village to take care of the patient like that. I think that's where I am as a nurse. That's my part I'll play. Thank you.
Thank you very much, Ms. Kisa. Dr. Mlawa, do you want to add something else before I go to the next nurse?
So what Kisa has just told me is right, because this my patient was seen by a dietitian. Because the part of we do the so-called obesity clinics here. So these patients who have got very high BMI, they're overweight, before they go in for surgery, they have to be assessed by obesity clinics as part of metabolic medicine, and I take part of that. In that clinic, you've got a dietitian. So this patient was seen by a dietitian already, trying to support her. Then you're right to mention about the role of psychologists, of psychiatrists, because most of these patients with chronic conditions, they've got some sort of mental health issue, so they need support with that. And also the role of the dietitian. So the dietitian is always there. And sometimes, if they are complex to manage patients, they are managing in a setting of multidisciplinary team. So when we talk about dietitian and weight loss, when you advise someone to lose weight, if you lose weight in maybe 2 to 4 kilograms, it brings down the systolic blood pressure from 3 to 8 or up to 10 systolic. Then diastolic can go down by about 3. So weight loss has got 3 advantages. One, by reducing weight, you increase insulin sensitivity and therefore better diabetes control and a better A1C. Because if you look at the pathophysiology of type 2 diabetes, one of the pathophysiological mechanism is insulin resistance. So by reducing weight, you reduce insulin resistance, you increase insulin sensitivity, and therefore control. Number 2, what's the effect of weight loss and the blood pressure? You get better blood pressure control. Number 3, what is the effect of weight loss on the cholesterol or lipids? When you lose weight, you reduce the so-called bad cholesterol, the LDL cholesterol, and therefore, if you look at a contributing factor for type 2 diabetes, if you've got high cholesterol, high blood pressure, you're overweight, you make diabetes worse. So overall, whatever Kisa has said is part of my multidisciplinary team, and that's how this patient, my patient, has been looked after or cared for.
Okay, thank you very much, Dr. Mlawa, and I do agree with that what Ms. Kisa said about the psych part. Yes, and then I appreciate the multidisciplinary team to be able to address that patient, because there's so many things that are going on other than just the disease process of the diabetes or the weight gain, and then the psychiatric part of that patient. So definitely has to be a holistic, because our goal is to make sure the patient knows what is going on, for them to be compliant for what we are teaching them. We can have the best team ever to try and educate these patients, but if the patient does not believe what we are telling them, they are not going to do what we can do all the surgery we want, but still the patient is going to behave the way they want. And so that is very, very important for both of us to work as a team to take care of this patient. So Mr. Katunzi from Tanzania, I know you do work with diabetic clients, and so using the same scenario that Dr. Mlawa has displayed to us and explained, and what Kisa has provided from knowledge with the patients who are experiencing diabetes, what have you experienced on your situation? If you can share using the same scenario. What is your education?
For this invitation. Actually, I really appreciated the scenario, and I was so much happy to hear the experience from Dr. Mlawa as well as Mrs. And we have the same experience here, and in my view, is not far from what has been said.
Okay.
But I have two important things that I want to add on. One issue, which is financial difficulties, especially for the patients who are mostly being sustained on insulin as well as the tablets, especially for the type 2 diabetes. It is always very complicated for them to handle the situation. So it is a great important for a nurse to intervene in the situation by explaining the goal, like what has been said by Wakisa, and also explaining the importance of how well by utilizing these two will be able, especially for the patients who are more obese. But as well, there is another problem on the issue of nutrition. According to my experience, I have seen that many of the diabetic patients, they are so much easily forgetting things. So I do work with the nutritionist, and always we do try to see on how we can advise the patient about the appropriate food to be taken. But has to be a ongoing process. It's not like a single day or like a week explaining the patient, despite of giving the handouts about what the kind of the food, even including the relatives, what to do. But many of the patients, because they do stay around, sometimes when they come to the hospital, the relative will come, stay with them for a few days, and then when they got ill, they stay alone. So it's a lot of the patient to know what to be taken and what not to be taken. So many of them, they do forget what to do. So it is very important for us to remind them, when sometimes we provoke them, as what has been said by Kisa, that we ask them sometimes that what are the appropriate food that we have to take, what is going on, and sometimes we see that there are some differences from what we had discussed already. So as a nurse, for sure, I have to explain it to the patient, but as well, sometimes we try to involve like what has been said by you soon after the relation of Dr. Mlawa. You have said that sometimes the doctor should not give the order and the nurse has to go and provide the medication. It has not be like that, because according to my belief, I do understand that the insulin, it can be a good medication, but as well it can be used as a toxic material. So as a nurse, I have to understand appropriately why the patient is getting this drug, and what is the appropriate amount of units, and as well what are the essence of providing the drug behind. This for sure has been bringing a positive impact, and as well our patients have been able to combat the situation. Though these two important, these problems are the big challenge, especially for the patient who might be used to take the tabs. Once you switch him or her to use insulin, it has to be a very big discussion. And sometimes, the fearing, when tell the patient that you have to use the medication, many of them, they do think that this is the end of their life. It's a part of my work experience that I have to explain the patient to understand the situation.
Mr. Katunzi, my understanding that you did work, or you're still working with a lot of clients that are experiencing diabetes. And you mentioned the financial difficulty, then yes, because if there's no follow-up or reinforcement of the knowledge, then the patient might not feel like they have to continue doing it every day, because type 2 diabetes is a lifestyle change, including you have to do regimen things like repetitive to make sure you maintain the glucose levels. So yes, if somebody cannot afford to keep the same medication or use enough insulin, they're going to skip some of them, and that is going to create an issue, or bring the glucose index without being managed, and that's going to bring issues. You did explain about the need to explain the medication, the effect, and that is the role of the nurse also, definitely, to make sure the clients or the patients understand, if I take that medication, what will happen, and if I don't, what will happen. And so we do acknowledge that you included that in the discussion. Dr. Mlawa, do you want to add anything else from what Katunzi just added? And then I'm going to let our pharmacist, George, jump in.
So I know about cost implications in terms of back home and other low resource setting. And I think 3 months ago, I took part in, there was a meeting in Muhimbili regarding different conditions. And I gave a talk on diabetes and technology. And one of the questions I was asked was that, how can you talk about technology? People don't have any basic needs like oral hypoglycemics. So we understand that. And we know that in other countries, like in the UK, most medication for diabetic patients are free of charge. They are subsidized, and therefore that's what we can afford. So for back home, of course, based on what the patient can afford, but also they need support. And that support has to be ongoing support. And that's why there's a role for the future to have proper setting in terms of, I don't know where Dr. Katunzi or Mr. Katunzi is working, in which setting. Is it in Muhimbili? Is it in a small district hospital? As the diaspora, we are trying to very hard to try and connect with our colleagues back home, to support them in terms of setting or supporting clinics or diabetes centers within the country. And we are working hard on that. And the future is, I think, it's collaboration.
Very much, Dr. Mlawa. I do agree that diaspora can be a huge part to support And then, of course, once we identify these areas that do need the support, whether it's education or resources, then yes, it will be very nice to work with our colleague back home to make sure they get the resource as needed, or the educational training if needed, to try and help our own family members back home in Tanzania. So I do appreciate Mr. Katunzi saying the financial difficulties with the medication, and I do acknowledge Mr. Dr. Mlawa just explaining the importance of getting those medication and support. So I'm going to invite Mr. George, pharmacist from Muhimbili, to come and give us, what do you have measures, or first of all, what medication commonly used in Tanzania for diabetes, type 2 diabetes? And then what are the measures to help people who cannot afford the medication? Because we know this one, part of the treatment for these individuals is to have adequate medication. And so if so, how do you address that? Mr. George?
Thank you so much for this platform. My name is George Msiba. First of all, I would like to say that I'm very happy to hear the scenario presented by Dr. Mlawa and other previous speakers. Before coming directly to your questions, I can add on my role as a pharmacist in this particular, my experience in this particular scenarios presented by Dr. Mlawa. As a clinical pharmacist, in my setting, it depends where I will be in the team. I can be in patients in a ward lounge, or I can be in outpatients in the pharmacy dispensing the medication to our patients. So being outpatients, I can have a minimal time to counsel the patient and to talk with the patient, but in a ward lounge, I can participate and give pharmacy practice like looking the dose prescribed to the patients, contraindication, as doctor said, taking metformin like example, we cannot give to the patient who creatinine is very high. Also, I can look the appropriateness of the medication, also the side effects by looking by listening to the patients and the other symptoms of the patients. So coming to a particular question you asked about the common medication used type 2 diabetes, the common medication you are using, about which modality we are using to help the patients who cannot afford the medications. We have also welfare department, social workers. This social worker, the patient is not able to manage to pay the bills, or if he's in patients fail to pay the cost of the whole period in the ward, they have to go to the office, talk with the social worker who will assess the condition, will ask the patient the condition, life standard, and know how to waive this bill and submit to a particular office, finance department, and deduct that bill, and the patient can get the medications. That's how we are doing in Muhimbili.
Great to hear. Thank you very much, Mr. George. That is an excellent, because I know for sure there's a lot of people who cannot afford the medication. Knowing that there's a road system, I'm hoping it could be, like transfer to all the areas, not only Muhimbili, to smaller hospitals. That's where people can get those support. But so Mr. Katunzi does work in the community, and if I'm not mistaken, I think he was in Iringa working on that area. And so those are the people who may not be able to afford the medication. So if that program was introduced in those local areas, definitely they can benefit, because as I said, for type 2 diabetes, you do have a number of things that they need to do in order for them to be compliant. And so I do appreciate Mr. George for adding that part. At least as a pharmacist, you've already addressed knowing the importance of medication and completing the dose. As one of the pharmacists usually used to tell us, make sure the patient complete the dose, even if they feel better, make sure they complete the dose. So yeah, so importance of that is that knowing that if the patient cannot afford them, there's a resource for them to get. And I'm not sure how widespread is it in Tanzania for people who cannot afford get that part. But I'm glad in Muhimbili you guys, and that is a great example to be emulated by the whole country. So before we go to the next scenario, I have a message from a nurse from Norway, originally from Tanzania, of course. So she gives us how she take care of how she take care of the patients who have diabetes, and what things that she goes through doing it before and during taking care of the patients. So
Hello, my name is Zainab Al-Jabri from Norway. I'm going to share my experiences about working with diabetes patients as a nurse. When I start my shift at work, it's very important for me to know the patient's history, to know if it's type 1 or type 2 diabetes, or if it's diabetes because of pregnancy. It's also important for me to know the list about the medicine the patient uses, because some of the medicine, they have a tendency to raise the blood sugar level in the body, such as steroids, for example, dexamethasone, prednisolone, even the some of blood pressure's medicine, they also have a tendency to raise the blood sugar in the body. So it's important for me to know if my patient use such kind of medicine. It's also important for me to know if the patient uses the insulin pump or insulin pen or medicine in tablets form, like metformin. Most of the doctors, they usually prescribes the insulin based on glucose level in the body and how much carbohydrates a patient's eating. So as a nurse, I have to follow and register these two things. When I have all the information I need, I go to the patient's room, introduce myself, and start talking about diabetes, insulin, if the patient have some questions that I can answer. Yeah. Most of the patients, they usually ask about insulin and diabetes in general. I usually explain like this. When we eat food, after digested, enter the blood system, the insulin that produced by pancreas help the glucose in the blood system to move into the cells where it's broken down and produce the energy that body can use. But when the pancreas is no longer produce the insulin, that is what happened when a patient have type 1 diabetes, or when the insulin is not enough to move the glucose to the cells, or when the cells does not react to the insulin. That's what we call the insulin resistant. The blood sugar goes high, more than normal. That's where the diabetes occurs.
Okay, so that was the nurse from Norway, and that's how she explained how she goes and talk to the patient after receiving the orders from the doctors. Because remember, the doctor will come and prescribe the medication and try to say what the regimen that patient should be adherent to make sure we manage or educate the patient about the medication and the diagnosis. So I'm going to bring it back to Dr. Mlawa before we move to the second scenario, which will be just to supplement some of what we'll be discussing in this scenario. Dr. Mlawa, anything that you want to add to what the nurse Zainab just added?
Yeah, can you hear? I'm going to add what the pharmacist said, plus what the colleague from Norway has just said. In terms of pharmacy, I think you're doing a good job given the setting. But I'll tell you, given my experience within the UK, I started working in the UK as a junior doctor. And my most worry was, what if I make a mistake in terms of dosage? when I write any medication, I can make mistake. But I want to tell you that having a pharmacist, having a nurse, having a physiotherapist, having a healthcare assistant, having cleaners, we work as a team. And the pharmacist is the most important person in the ward. I'm in the ward this morning. I've seen about 30 patients, but out of that, some of them, I don't know their drug history. The pharmacist will come and tell me that I've gone through with the patient, this is a drug history. The pharmacist can call the general practitioner, the regular doctor for those patients. They come and tell us that the dose was this and that the dose you've written is wrong. So it's just about working together as a team. And we always, I think the pharmacists are friends, especially most junior doctors, because they've got experience, they support patient care, they make sure that the patient is safe. So it's all about collaboration and collective effort and coordination. In terms of available medication back home, I agree with you. I know you use the metformin is number one everywhere, unless there's contraindication. I've been back home on holidays. I've reviewed patients with diabetes back home, and I know the difficulties in terms of affording those medications. I think the long-term solution will be to make sure that we lobby or talk to the stakeholders in terms of supporting these patients with diabetes, because diabetes is not just infection. Diabetes is a long-term condition, and that has got impact in terms of economical and the physical health of an individual. And if one person has got diabetes, has got chronic condition, it's not his own problem. It affects the whole family, and that's important. And what the colleague from Norway has just said in terms of approach to looking after patients, that's correct in terms of knowing what they're taking and what is their dosage, and explaining that why you should be taking these medications, and the way they support them, whether they're on insulin long term, they're just on tablets. Do they come? Is it a new diagnosis? And what the condition have they come in? Are they pregnant or not? Are they using insulin pump? That's a technology, and that's important. But we cannot talk about diabetes in current climate without talking about diabetes with COVID-19. So I want to add on this in terms of my experience. I've been in front line looking after COVID-19 from last March. I'm looking about after this patient. Even now, we are getting more sicker patients. If I tell you that in the first wave, we didn't have enough medication to treat COVID. Now, based on different trials which have been done for the past 10 months, we have got new medications to treat COVID that include the antibiotics and the steroids. So we are using dexamethasone in patients coming with COVID, those needing oxygen or needing ITU admissions. Some of them are diabetic. Some of them, they're just on diet, but diabetic. Some of them are non-diabetic. And if they're coming with COVID, once you start them on steroids, they will have very high sugar levels, and therefore that's difficult to control. And therefore managing their diabetes is important, because if you've got diabetes, you are inpatient, you're hospitalized for maybe for sepsis. Having a persistent high sugar levels of more than 10 millimoles, that I'm using UK millimoles, is a poor prognostic factor. And therefore making sure that these patients are in hospital, maybe they are taking methadone, you make sure that their sugar levels are less than 10 most of the time, and therefore we start insulin for those patients who are inpatient to get on top of their diabetes control.
Thank you very much, Dr. Mlab, because you just stole my line. That was my next question before we get to the second scenario, that diabetes and COVID. And as what Ms. Zainab from Norway just mentioned, that yes, as a nurse, you need to understand the interaction between the medications from one diagnosis to the next. And as a nurse, you work with the doctors in all those interdisciplinary team to be able to figure it out, if giving this medication to help them reduce the inflammatory response and stuff. But then also, does it predispose this patient to more complication for their actual diagnosis of diabetes? So I appreciate that, Dr. Mlawa, you answered my question even before I asked that. So thank you. We're going to go to the second scenario. The second scenario is going to be kind of real short because we already discussed quite a bit of diabetes, but then this one is diabetes in pregnancy. So we're going to probably add to it, and it might be a little bit short, but exciting just to learn about the diabetes in pregnancy also and how it affects. Okay, so the second scenario was a 35-year-old Asian lady referred to a diabetic clinic by a general practitioner at 7 weeks or 40 weeks pregnant. And so she is type 2 diabetes, was diagnosed 2 years ago. She was found to have low vitamin D. Current medication is the folic acid, metformin, vitamin D3, 800 units. And then part of investigation at admission, we included blood rate, which was HbA1c was 53, and the glucose was between 6 and 9. So this was the scenario provided by Dr. Mlawa, and I'm going to give back to Dr. Mlawa and give us the background and what he did to take care of this patient. Dr. Mlawa? Dr. Mlawa?
Yeah, thank you. So as a part of my role, I've done diabetes in pregnancy and also taken part as part of the interdisciplinary team or multidisciplinary team looking after patients with diabetes. So if this is a 35-year-old lady, she's now 7 weeks pregnant. If you look at within UK, most type 2 diabetes patients are under their general practitioner. They are regular doctors in the community. And so she was referred to the diabetes clinic because she's now pregnant. So this is somebody who is known to have pre-existing type 2 diabetes. She's become pregnant. And the guideline in terms of managing these patients before becoming pregnant, they need to go into the so-called preconception clinics. So somebody who is non-diabetic, whether they're type 1 or type 2, whether they're diet controlled alone, they need to be seen in preconception clinic, or those women who had previous gestational diabetes. So some women, they got 1 or 2 children, they become pregnant, they want to have another child because they were known to have previous diabetes in pregnancy or the so-called gestational diabetes. They need to attend the so-called preconception clinics. So for this patient who was referred to us, not attended the preconception clinic. So she is 7 weeks pregnant. She's known type 2 diabetes for the past 2 years. So initially, as somebody who is not pregnant, she was managed just with diet alone. Then it didn't work. She was put on metformin, okay? But also she's known to have low vitamin D. So she was taking vitamin D anyway. So more in the UK, we get it's a very short summer, and anyone who is of dark-skinned Asian or Africans, if you try and check their vitamin D, it will be very low because of lack of sunlight. And if you look at her medication now, she's taking folic acid, 5 milligrams. That's a high dose of folic acid. She's on metformin. So in pregnancy, patients who are non-diabetic, patients with some thyroid disorders, I look after those patients as well. Once they become pregnant, you put them on high dose folic acid, which is 5 milligrams, for 12 weeks or for the first trimester to make sure that you try and avoid congenital defects such as spina bifida. So we use high dose folic acid for the first 12 weeks or first trimester. Then after that, we can go and take maybe small dose of folic acid, which is part of pregnant care or multivitamins. So if you look at this patient, glucose level is between 6 to 9. And HbA1c, A1c is about 7%. But there's a difference between a normal non-pregnant diabetic patient and the patient who is now pregnant and diabetic. So the target range glucose changes. So as the rule of thumb, at least based on our guidelines in UK, the glucose levels in somebody who is pregnant and diabetic before meals should be less than 6. Okay, to simplify that. And 1 hour after meals should be less than 8. So that's a very tight glycemic control. And these patients, once they're referred to general diabetes clinic for this patient, I told her that I'm going to refer you to a joint antenatal diabetes clinic. That is a clinic whereby you are seen by obstetrician, then you are seen by a diabetologist at the same time. You get the best care. So looking at the glucose level of between 6 to 9, metformin alone will not work for this patient. We want to get a better diabetes control, that we want to make sure that before meals, sugar level is less than 6, and after meal, 1 hour after meal should be less than 8. That's being more lenient, but I think if you look at the NICE guidelines, it's even tighter. Our own local guidelines is even tighter. So for this patient, she continued to be taking metformin and folic acid, but we added, as when required, short-acting insulin. So we use Novorapid as when required, short-acting insulin, telling her that just make sure, look at this. We give her a diary saying that before meals should be less than 6, 1 hour after meals should be less than 8. If it's above that, you can take the short-acting insulin as when required. So 1 unit of Novorapid can bring the sugar level down by 3 millimoles, if I'm using UK units. So that was the initial phase, that we are starting you on insulin as when required. But as the pregnancy advances, there's a tendency of increased insulin resistance. That's a pathophysiology of type 2 diabetes. And therefore, the insulin requirement or requirement for medication trying to lower the sugar levels goes up and up. So for this patient, eventually, the short-acting insulin, which was supposed to be taken on as when required, she was taking with meals. Initially, 2 to 3 units with meals. And these patients, they are well looked after because we review them once every 1 to 2 weeks. So every week they'll be reviewed, then every 2 weeks they'll be reviewed. Looking at their control, they are seen by a dietitian, they are seen by a midwife, they are seen by obstetrician, and they are seen by a diabetes specialist. So what do we do with these patients? So they get a booking scan at 10 weeks. I'm not an obstetrician, but I know that they get a booking scan at 10 weeks. But by 12 weeks, they have to have a normal scan. I think they have a scan at 12 weeks, then at 20 weeks, then 24 weeks, then at 36 weeks. So these patients, they get a lot of monitoring, close monitoring. We see them more regularly. So one can ask, what's the reason for this patient to have a different target glucose range? There are reasons, because being diabetic and pregnant, there are different risk factors. So I'm going to give you an example. If you get a poorly controlled diabetes, there's a risk of this patient to have big babies, the so-called macrosomic babies. And if the babies are born maybe more than 4 kilograms, there's a risk of getting birth injuries. There's the risk of having cesarean section. And one of the birth injuries is called shoulder dystocia, whereby the children can have effect on that. So that's one example, that being diabetic and pregnant was a risk factor. But also, if you've got a poorly controlled diabetes during pregnancy, there's a risk of making preeclampsia or hypertension in pregnant worse. So I'm trying to mention few things which are associated with bad diabetes control or poorly controlled diabetes. So for us, these patients are very special patients. They are well looked after. They are looked after in a joint antenatal diabetes clinic where you get dietitian, midwife, obstetrician, and diabetologist. And then they've got proper scans, booking scan at 12 weeks, another scan at 20 weeks, another scan at 36 weeks, and also there's a planned delivery. So are they going to deliver by cesarean section or normal vaginal delivery? That will be supervised. So one is going to ask me that, okay, is metformin safe in pregnancy? That's the question someone is going to ask me. So when I was a trainee, I think a few years ago, we weren't sure about the evidence for metformin, but we've got evidence for metformin that is safe in pregnancy. And therefore, if they are type 2 diabetes patient, they become pregnant, we continue metformin alongside insulin. If they were type 2 diabetes taking sulfonylureas such as either gabenaclamide or glucoside, we stop those medication, we introduce insulin, but we always continue metformin. So in summary, I've talked about a case of a 35-year-old Asian lady who is non-type 2 diabetes for the past 2 years. Now she has been referred by her general practitioner to our clinic with because she's 7 weeks pregnant. And that her care, these are special patients, and therefore they need special care, and therefore the best practice is to be seen in the joint antenatal diabetes clinics where there's a multidisciplinary setting and the patient had a very good care with a delivery of a healthy baby.
Thank you very much, Dr. Mlawa, for that rundown on that clinical scenario. Ms. Nancy Littner, who was certified diabetic educator, she's a nurse for many years, and she used to run the program in Ohio. Unfortunately, she was supposed to be with us so she can contribute her expertise on this second scenario, but I'm gonna talk to her afterwards. She has an emergency in the family. What I can add to it with my experience from working with pregnant patients who are diabetic is what Dr. Mlawa just mentioned. And I think before he said about the pathophysiology of diabetes and in pregnancy, the increase of resistance during the as the pregnancy grows. So that means whatever they were doing before might not be working. And then so usually as a labor and delivery nurse, admitting this patient in labor, then you have to be cognizant of that fact that if we are not controlling that mom's glucose, that baby is going to be born with complications of glucose. First of all, if the diabetic was not controlled during or pre-pregnancy or during the beginning of the pregnancy, that baby is going to end up with macrosomia, what Dr. Mlawa just said. And as a labor and delivery nurse, I know for sure if mom has a history of diabetes and she's in labor, we anticipate there's potential of having birth trauma, meaning that baby is going to be too big. And if the bigger the baby, more trauma is going to happen at the delivery. Okay, are you going to end up delivering that baby vaginally if mom comes in labor? Sometimes we try, sometimes not, because we measure the baby and make sure baby can fit on the pelvic inlet. And or if we decide to deliver the baby vaginally, can baby get trauma? Yes. Dr. Mlawa just mentioned shoulder dystocia. That means when the baby comes out, the baby's shoulder gets stuck because the baby's bigger and doesn't fit on the mom's pathways. So there's so many things that as a labor and delivery nurse, just knowing that the pregnant patient is a diabetic, there's so much stuff. The moms will have more fluid, amniotic fluid surrounding the baby, meaning that the baby might have lungs issues when they come out. So we always equate a diabetic mom might end up having a baby with respiratory distress. As a labor and delivery, I have to prepare for mom and baby to make sure I protect the mom and baby at the delivery. So we have to anticipate things that could happen. So just knowing as a diabetic, we do need to focus on the pre-pregnancy and first trimester, which is week before 13 weeks, to make sure we manage that glucose and make it as controlled as we can. Dr. Mlawa just shared those numbers for UK. It's almost close to what we have at US here. And I'm going to ask Mr. Katunzi and Mr. George for the levels that they use in Tanzania. But then exactly, once we control that part, then we notice the baby has a better chance of having less trauma at the delivery, because if mom have a control glucose, that means the baby is going to go with the average weight versus too big. And then so at least that we facilitate that baby to be born vaginally. That we preferred method versus C-section. However, if the baby is too big, C-section is a better option because we don't want to traumatize the baby at the delivery. So there's so many things that we have to juggle with a pregnant patient with a diabetes than just a regular patient without that diagnosis. So I appreciate Dr. Mlawa for introducing that scenario. And as I said, we add afterwards what Ms. Nancy, because she has worked with pregnant women, she can give us just a few minutes to add that when she gets a chance. I am gonna add, if Ms. Kisa have any experience with a pregnant patient who is diabetic, either in ICU or anywhere else, or Mr. Katunzi, if you can add to it as experience for your nurse, as a nurse. Oh, let's start with Ms. Kisa. Go ahead, Ms. Kisa.
Okay, thank you for presentation, the past people who presented. So during the COVID, as we know, a lot of patients either cannot go to the hospital because the practice is closed. And some of the patient doesn't have electronics, maybe let me say electronics, maybe they don't have Wi-Fi. So we see a lot of patients coming in the ICU with the COVID. So COVID with the pregnancy doesn't go well together. We have young people who came to ICU, as my experience, with maybe 26, 28, and sorry. And they're very sick. So it's a matter of life and death, either to take the baby out or the mother's gonna go. In my experience in the ICU, we have to deliver the baby by C-section, and the baby, some of the babies, they were not matured to be taken out. So like at 29, the baby is not ready. So there's a lot of risk, but however, we have to work as a team. Again, we have to work with OB, we have to work with every service to make sure the baby was safely delivered. And luckily, one of the patient was delivered. The baby was well delivered, and the baby survived, the mama survived. However, in another case, the mommy didn't survive. The baby was okay, but the mommy didn't survive. So there's a lot of things need to be done in society to tell the family that, you know, there's a risk. It's not because you're pregnant, you're young, the COVID is not going to affect you. The COVID affects, and the outcome can be different. The baby, maybe because it's not mature, the lungs is not well developed. Could it be, the baby could have some disability because the baby is too young again. So the diet also is important again, and to encourage the parents that to take the folic acid. The folic acid is very important in the first trimester, because if you do not take care of or you don't take good care, you may have spinal bifida. We do not have a lot of spinal bifida in United States, but however, I don't know how about Tanzania. So do they have only folic acid? They may not have folic acid, but you have to also support or know which food is high in folic acid to tell the mothers that they need that, which is leaf, I think it's a leaf, green leaves food, beans, liver, red meat is good. So to encourage the parents, maybe they may not afford the meat, but also there's leaf, which is, I think Tanzania is very, or maybe third world countries, they can be, it's available. Avocado, I think is good. Also citrus fruits, like orange, lemon, also they're all good. That is my observation. And I think that's it.
Okay.
So that's a very good experience from what Kisa just said in terms of patients who are coming with COVID, and then they end up ending up in your ITU, and it's very difficult to manage. So one of the things in terms of preconception clinics, when patients are seen before becoming pregnant, I know with COVID now is almost 10 months or 12 months since COVID came, and that has affected a lot of things. People are just staying at home; they're not getting their appointment with their doctors, and therefore they might not get an advice. So in the UK, for instance, we advise somebody who is non-diabetic or previous gestation diabetes, or whether they are type 1 or type 2, that you can become pregnant if try to get HbA1c less than 6%, 6.1%, for instance, which is a difficult task to achieve. But we advise them using contraception if their HbA1c is above 10%. So if the diabetes is very poorly controlled, for the short term, we can advise them that make sure you use contraception. But if it happens that they are pregnant, of course, we congratulate them and make our situation.
Thank you, Dr. Mla. Yes, we always say job security for somebody who is pregnant in our world, but yes, thank you. Mr. Katunzi, did you want to add something there?
Yeah, thank you so much. I was so much delighted with the last statement. In fact, I just want to share. I just want to share my experience with diabetic. Diabetic pregnant women, and as well as the use of folic acid. Starting with the pregnant women, I think I have met with 2, if not 3 patients who were pregnant women. And in fact, they had a bad obstetric history, and they never know if they had diabetes before. So the patient, the one that was brought in our clinic, she just came, and when she went to the normal antenatal reproductive clinic, they found that the patient was having high blood glucose, and they decided to brought the patient to our clinic. And when we started to crack the patient just to test to know the underlying basement, for example, the aggregated hemoglobin, to see the blood glucose level and the other investigations, it became clear that the patient was typical, and he was a long-standing problem, though she didn't know. And we started to advise her what to do and some of the medication that they had to do, but she was a bit aggressive. That was an ethical dilemma, and for sure she had a bad history of fetal microsomic babies, like 3, if not 4, and she had a lot of complications during delivery. So we advised the eye, and we had to intervene. So it took her like 4 days, and we were like trying to call her several times, insisting her, and we also tried to involve the relatives. We told her to bring the husband in together with the close relatives, and we advised them, and we told them the essence and what was the practical point of view depending on the situation she had. And she was able to adhere with the situation, and actually we gone with her through metformin until the last day of delivery. We never exposed her to insulin because the status of glucose was stable and all during the pregnancy. And fortunately, she was able to get a baby, and the baby was almost like 3 kgs, which was a good news. And now the baby is doing fine. So this is one of the compliments that we had. And another lady that I have met, she's like a 65-old woman, and in fact she had diabetes, but she didn't know that she had it. So she was telling us the history on how the baby, their babies, like 3 babies, they died soon after delivery, and she was telling us that the body weight of the baby always were greater than 4 kgs. And we come to realize that she had a problem of diabetes and she didn't know. So we told her that maybe if we would have understood the situation before, maybe now she could have those babies, but we are sorry for her. So that is the problem. And as well, what I came to realize when we are doing the supportive supervision, I came to realize that many doctors, they don't know the baseline treatment for the pregnant women. Maybe this is an area that we have to cement on, because many of the doctors, when they see the diabetic patient, they will think about metformin and the glibenclamide, which is the most defined drugs here. And as well, they come that the patient jeopardized on some of the medical conditions, because I know glibenclamide is not a good drug for the pregnant women. So this is one of the shortcomings that is prevailing. So now I give this as a challenge to Dr. Mlawa. Maybe when we be thinking on how you can try to implement the strategic plan about the treatment of diabetes, you have to consider this as well. Coming on the point of folic acid, I think the antenatal dialysis clinics in Tanzania are well situated, that all the mothers that are attending the antenatal visits, they do provide the folic acid, which is a good thing. Though the question comes on the issue of the taking of the pills for these pregnant women. Many of them, they have a bad ideology because folic tabs, they do change the pieces. So many of the pregnant women, when they took tests and they see that they opt not to take the drug. So as a nurse, I think the moment when I used to work in RCH, I used to educate them that the care of the fetus has nothing to do. So what is important is you have to take the drugs so that you can prevent the complication of the baby. Thank you.
Mr. Katunzi, before I give it back to Dr. Mlao, I'm going to ask Mr. George, your experience with pregnant women medication, if there's any difference, and any information you can share with us.
Yes. Thank you, Dr. Elliot. As Dr. Mlawa said, the guideline for diabetes management in pregnancy women are the same. Insulin plus metformin, although sometimes as a pharmacist, I encounter some prescriptions with the metformin and the glibenclamide, and when you ask the doctor, they always they listen and they change the prescription. Maybe I don't have a interesting case like previous speakers. My contribution as a pharmacist in white rounds, when I'm in the team of the GY, we concentrate entering some parameter, because we know these pregnant women are very delicate, as Dr. Mlawa said. I really concentrate in some parameters to see if the plan will attain will achieve the goal. I will look if metformin and insulin has caused some adverse drug reaction to these patients. Sometimes I can look on side effect by asking the pregnant woman if he's experiencing some side effects. Also, always I try to advise doctors to order creatinine to every visit. If the patient is outpatient, to every visit we have to know the creatinine for these patients, because we know the side effects of metformin and when the patient is renal compromised. That's what I can share.
It's in pregnancy or diabetes in adults.
So I think that's a good, both Tunzi and the pharmacist. Thank you very much for sharing your case and your experience. So I know that being a big baby, say maybe previous big baby, born as big, it means that this patient, maybe they were diabetic without knowing, therefore they got gestational diabetes. And well done for managing that patient and who gave birth to a normal baby, which about 3 kilograms. I think long term is to say that in terms of managing these patients, they don't just come just at the clinic or often guy in the clinic. I spoke to my colleague who is the vice chancellor at Muhimbili, Professor Pembe, is my classmate. He's the option guy consultant. And also I tried to speak to him a few years ago regarding what's your practice in terms of how do you look after patients who are diabetic or who have got thyroid problems and they're pregnant. What's your best practice? And I gave an idea of saying that there's a chance of making sure that you create a dedicated, a multidisciplinary clinic where you get diabetologist, dietitian, midwife, and then optional guidance consultant to look after those patients. So the pharmacist, Mr. Msiba, talked about looking at the drug charts of patients in the optional guidance ward, and some patients you've used glibenclamide in your setting. Yes, I've got evidence that when I was training in at Southampton University Hospital, one of the consultants was using glibenclamide, which is a group of sulfonylureas. It has been used in other centers, even in America. One of the professors from America, I think from Washington, he gave us his experience in terms of using glibenclamide. We know that all the drugs cross the placenta, okay? But I think the previous study showed that maybe glibenclamide causes the placenta less so compared to other medications. So it has been used, but it's based on experience of a given center and a given treating clinician. The pharmacist also mentioned about looking at blood test results, including kidney function. So somebody who is on metformin, for instance, there might be a contraindication. So the contraindication to metformin, for instance, is a creatinine level of more than 150. I think using UK units, or EGFR of less than 30. So that's a total contraindication. So we don't, even if they are not pregnant, then we stop the metformin. But as long as they've got normal kidney function, we know that metformin is safe in pregnancy, and we have got evidence for that. That's what I can say.
Okay, thank you very much, Dr. Mlawa and Mr. George Musiba and Mr. Katunzi for that part. So I'm gonna bring the message from Zainab, and then I'm gonna ask each one of you to give your final information. So now as a patient, you have to convince me or teach me things that I need to remember when I'm going home after receiving this diagnosis. So I'm just gonna give you that 1 minute to think about it, and then let me go to message from Zainab, and then I'll go back to you guys.
I usually show my patient how to inject themselves and give some tips like inject in different spots each time, change the needles after each injection, store the insulin in the fridge or in the cool areas, store the needles disposal in the container, seal it, and deliver to the nearest clinic or pharmacy. I also talk about the feelings, how they feel. If the patient is afraid of needles, it's very important to talk about it, because it's very easy to skip the insulin doses. Yeah, and that is not good. It's also important to talk about the insulin overdose. This can easily occur. For example, if a patient used rapid acting insulin injection, that should be taken with the meal or before meal. If the patient is not eating, then inject him or herself by that kind of injection. It lowers the blood sugar to the dangerous level. That could be life-threatening. I usually advise my patients, if something like that happens, they have to eat quick candy, drink soda, eat glucose tablets. Most of the patients who uses insulin, they have glucose tablets at home. If the situation don't get better, so they have to inject themselves by glucagon injection. All the patients who uses insulin, they have that injection at home. And dial the emergency number. It's also important to talk about the diet, what kind of the food the patient can eat. Type 2 diabetes, we can control by engaging proper diet, physical exercise, 150 minutes per week is very good. Stop smoking for those who smokes. Checking blood pressure and cholesterol regularly, along with medicine. But type 1 diabetes, they depend on insulin and engaging in proper diet. They have to live with insulin injection for the rest of their lives, because their pancreas are no longer produce insulin. When we talk about diet, proper diet, patient with diabetes should eat slow release carbohydrates such as brown rice, brown bread, green vegetables, nuts, seed, sweet potatoes, etc. They should avoid fast to release carbohydrates. For example, white bread, white rice, candy, cookies, potatoes, dried fruits, soda, etc. And drink water regularly. That helps rehydrate blood, which,
like what we as nurses we call like a discharge instruction. When the patient has received a diagnosis and now the medication has been assigned to her, and then now they're going home, what do we need to do? So that I said, I'm going to put myself as a patient, so you guys have to tell me things that I need to go and do at home, so then I can prepare. I will know what I need to do, what I need to eat, and how to manage my diagnosis. Okay, I'm going to put Dr. Mlawa last. Sorry, to start with Kisa, Miss Kisa, just within a minute or less, anything that you need to give a tip to a patient with diabetes.
What I'm saying, like, I went through the gestational diabetes, and it is hard, it's scary, because you really don't know what's going to happen to you, what's going to happen to the baby. But support is very important. Follow-up is very important, because I'm grateful that I was here, and then I got every support that I needed. So the baby has to be taken earlier. And as Dr. Mla was saying, the baby was growing so big. If there was any chance to have to deliver the baby by normal vaginal delivery, I think I'll die. But I have to do C-section. It was arranged. But support from family, from the husband is very important. And it was so many appointments at the point I was like, I don't know what to do. So every 2 weeks, and then after that, every once a week. And it was really scary. And you have to check your finger sticky before you eat. After you eat, you have to get insulin. And the baby, when he was born, really, his sugar was low. So I have to breastfeed the baby, which I have C-section, and the baby wanna eat, and eventually they have to feed the baby, and they have to monitor the baby if he don't have no complication. And then after you finish to have the baby, you are not in the wood done. You have to still follow up to make sure you maintain your weight, you maintain the diet, because you don't know what's gonna happen. So it's very important to make sure you do the right thing. And this education is never end. You don't only focus on the patient you see, but you can use that education to teach your patient who they're gonna teach others to be safe with the pregnancy. And that is my contribution. But thank you so much for this. I'm learning a lot from both of you. And then I really appreciate being in that group.
Thank you very much, Ms. Kisa. Let Dr. Mlawa close it up with all the education. What are the things that the patients to ask if they're coming, and what are the things that you need to teach them after you give them the diagnosis? What are the things that you need to teach them, so when they go home they can be compliant and hopefully don't come back with complication, but come back when they schedule appointments?
So I think the two scenarios I've shared, especially the one, I start with the type 2 diabetes patient who is overweight and is already on almost maximum therapy, being both on oral therapy and injectable therapies, is that to take their medication regularly. And that's one, because being compliant helps with everything. And for that patient who was awaiting surgery, is that the take-home message for her will be, in order to reduce complications of the operation, you need to have a better glucose levels or sugar levels. But above all, making sure that you adhere to the modifiable risk factors such as good diet, exercise, and then weight loss. That will help you to get better diabetes control, because doing those things not only help with diabetes, but it help with getting cholesterol level down, especially the bad cholesterol, the so-called LDL cholesterol. It will help to get better blood pressure control. In terms of patient who is pregnant, she's now 7 weeks pregnant. she's being seen in a joint antenatal clinic, which is a best practice, is that to ensure that she's compliant with that. She's been given a dietary advice, so she's compliant with that. We've initiated insulin to make sure that she takes her insulin regularly, and also to make sure that she doesn't miss her appointments. That is the joint diabetes clinic appointment, but also she will have several scans during her journey as a pregnant woman. Then after delivery, what is going to happen is that whatever good things she has learned during pregnancy, she has to continue with that. And if she wants to plan for another baby, she needs to be seen in the so-called preconception clinic. That's very important. That's all I can say for today. And thank you very much for allowing me to take part in this discussion.
No, thank you, Dr. Mlawa, because this was very educational, and I, as a nurse, definitely working as a team is the monumental task in ensuring patient safety and making sure the patient understand what we are educating them or we are treating them. It is important for them to be compliant so they can be part of the part of the plan of care. And then also as patients understanding what we teach them, then they're going to be healthy when they go back to their home life. And of course, as a diabetes, definitely everybody is going to require, it's almost like we have to teach the whole family, because I think one time Kisa said the family also has to be involved, because somebody might be doing groceries or getting the food or preparing for the food and offering the food. So that person also needs to know that either one of the family member has diabetes. So we need to be able to do things that is going to support doing exercise. So maybe put the whole family in a regimen so to support somebody who has a diagnosis. So it is a very, very good experience, and I appreciate all your times. I know we took more than what we thought, but I think the discussion was helpful for the nurses to know what they need to do as their role. And then as a patient, they need to know what they can expect from our healthcare providers. And you presented very eloquently to a physician standpoint what the expectation you have to the nurses and the patients. So we can all work together. And the pharmacist, Mr. George, thank you very much for sharing your experience from Tanzanian medication part, and then Mr. Katunzi for your experience with the patients, and Ms. Kisa for as an ICU nurse putting that part. And also so thank you to Ms. Zainab for sending the message. I know you could have been here as a member as a nurse. She's always in the unit taking care of the patient. So thank you very much. I see Mr. Mlawa. Thank you, thank you, thank you.
Thank you very much.
Okay, bye. If you're interested to get more information about the QHSC Health Conversation Series, we can come and follow us on Facebook, YouTube, Twitter, Instagram, or you can send your concern or questions to dr.gabone.qhsc @gmail.com, or you can come and visit our website at dr.gabone.qhsc.org, and then you can learn more on what topics is coming. And anybody who is interested or wants to share their expertise, they're always welcome, and we can use all our knowledge to educate and train healthcare workers and improve the health of our family members and neighbors in the whole community. Welcome and enjoy the discussion.
Drgaboneqhsc.